Okay, welcome everybody. Thank you all for joining. Probably a few more people might join later. Thanks for coming to the Bananas. We have an exciting program. You see a tentative program here, people presenting. I just also want to let everyone know about the Banana course in April, in-person course in New York. I'm sure most of you know. If you don't know, here it is. There's some information on the bottom. If you're coming to the course, that's fantastic. Please bring a case. Please, select a case. It could be, or a few cases, whatever. Could be complication, could be a question about what to do. Some people show cases where they're not sure, how to proceed. It's for our evening discussion. It's a fantastic part of the course. And so if you're coming, great. If not, please spread the word so more people can make it. And with that, let's start. We'll start with Professor Chapot to show his case. Rene, thank you so much. I think you might be muted, and when you stop sharing, you should be able to share now. Can everybody hear me? Yes? Did something
No.
technical happen to Rene?
Yeah, because he just disappeared. So,
Okay, let's
oh no,
see.
there it is.
Okay, perfect. Okay, let's see if uh, there's any. Okay, great.
Okay,
Rene,
so
we
it
see your
worked
screen.
now. It was a bit long.
Yeah, that's good.
Yeah, yeah.
So I'll be happy to start today's session, and I will start with an issue that I had while treating this very small, very uncomplicated AVM. That's a small occipital AVM that looks like a piece of cake. It's something where the chance to do something wrong is definitely low. And we can see that the AVM is fed by the left PCA. And if we look at the arterial circulation, we see that that the PCA is also visible and the AVM is being filled here. And we may wonder, of course, we can place a microcatheter inside to do it by the arteries, which is the usual way to do. We feel that the chance to diffuse within the whole AVM is usually better by the vein. So after having a microcatheter through the posterior circulation, we went to the left PCA. The magic is in place. The vein is also very simple to get from the straight sinus backwards, and the chance to diffuse in all the compartments by the vein is always higher from the artery. I mean, to get an occlusion from the artery of the whole AVM, at some point you need to go from the artery to the vein and then back from the vein to the artery. So that's why we prefer to take the vein to diffuse in all. So you see here that a guiding has been placed, a Fubuki in the straight sinus. A combination of two catheters has been placed in the vein in order to make a pressure cooker, to put some coils and glue, and to treat the AVM, which has been done now. And yes, the AVM is cured. Nothing very spectacular, everything to be expected. And when the patient wakes up, he has some clinical issue because he's got a hemianopsia. And we don't really see that some artery is missing, but we do an MR the following day. And when doing the MR, we can see indeed that there is a significant ischemia. And I don't know why. So what could it be? I mean, the AVM is cured, but the goal was to cure without having some limitation of the visual field, and the patient has hemianopia. So we go on for, shall we discuss? Or, I mean, now
Yeah,
I don't think we have any element of answer, but maybe we can still already discuss now.
Yeah, let's see what people let's see.
Okay, so here's a control angiogram, which is arriving now. This is the posterior circulation, none of the branches of the PCA is missing. They're all there. And if we compare between
Are
the
they missing or
before
not?
and afters, this is after, this is before. We can play that game, which we love to play, in trying to search all branches. If we see this one, and the other three above, we also all see them here. And
I have a question, Rene,
yes,
if I may.
please.
We could see the AVM also from the carotid, right? Internal carotid.
Yes.
So the posterior cerebral branch, which we could see from the carotid, is the same that we see from the posterior circulation, or is it a different branch? See what I mean?
Can you go back and show it to us, please?
Yeah, because they were never diluted, neither one. And so I wonder.
It's true it's not diluted. Maybe I suggest to proceed a bit more, and then we'll answer to your question.
Thank you.
But
I think one more observation, potentially, is if we look at the lateral view.
Yeah.
And if we see the number, like it seems like there are some vessels potentially missing, or like parenchymal territory missing, where we'd expect the occipital, sort of the occipital pole to be. Like you see how it's a little bit washed out. Now, is that because of the sump of the AVM? I doubt it. It's not a big AVM. So, there's something else that's a little suspicious there to me. And you could see that in the frontal plane.
If you look at both PCAs from the vert, you see that they are very similar on the AP. And if we look on the lateral to compare the number of branches, I don't see, I took the time to look at it, and here I don't see any branch missing. For me, it's very,
but if we see,
much the
Rene,
same.
to Max's point, if you stay on this image, if we're looking at the straight sinus, just above the straight sinus, right, on the back, there is a wedge of lack of vessel, just above the posterior straight sinus, like a torcula essentially, just above the torcula. There's the area, lower than that. Yes, there.
So,
there.
but this is pre-embo.
Yes,
pre-embo.
Yes, that's the thing that, my observation is that pre-embo and post-embo is the same, but there seems to be almost like a wedge of non-opacification of that territory. So in a way, that's why the ICA becomes important, because to review the ICA again, because it almost looked like that territory may be filled by the ICA.
Yeah. So now we look at the ICA on the follow-up. So it is here post-embo, and we see indeed that there's, again, PCA branches coming from the ICA. We're not surprised. And here is pre-embo. And if you compare the pre-embo and the post-embo, at some point, you may realize that this artery here, this one, if you look post, it's missing. Okay. So here we have everything.
And we also see maybe a little bit more PL vessels, right? There's more in the post to try to reconstitute it.
So how to explain this? Indeed, if we look at the initial pictures of the posterior circulation, and if we compare this with the pictures of the ICA, what we see is what Dodi pointed out, which is that it's not the same PCA. There's a duplication of the PCA. You see here the PCA on usually you look on the lateral view, it's more or less the same, but it's still different. But on AP, you may see that this course here is different than this course here. So not the lateral view, but the AP view. So how can this be explained? Obviously, there is a duplication of the PCA that I missed. And during TVE, I was controlling the feeder from the PCA, but I did not control the reflux from the vein inside the feeders and PCA from the ICA. And in retrospect, by looking at the embolization, this is transvenous embolization. And this here is a retrograde filling of the artery from the vein to the artery, which is always likely to happen. So that's why we have always a microcatheter to control the patency of the artery, whether we continue or not. But here I was not able to control it because I missed the fact that we had the duplication of the PCA. So usually I think that transvenous is significantly more helpful and has less complications and is more efficient. But here it turned out to be counterproductive because if I would have gone through the artery, controlling the other side, of course, then at that time, I would have understood that it was something else.
Thank you. This it's a very important case for all of us to see. You know, this is some sort of like variant that we all know and we all talk about, right? But when you have the case, it may not be this straightforward to understand in this particular image that indeed that one is the anterior. Essentially, that big vessel is the anterior choroidal artery. That's the point, right? It's the anterior choroidal artery that kept part of the territory of the PCA, and you know, in this case, you know, this turned out to be clinically incredibly relevant.
So retrospectively, yes, when the PCA is filled by both ICA and basilar, we see that the PCOM is a bit smaller, that P1 is a bit smaller. We see here some connection, but I guess that the focus was mainly on the AVM, and we saw a PCA, and I did not pay attention to check.
No, this is very generous of you to share a
patient.
complication with us. I mean, that's you know, and that's where the teaching come from. You know, how to prospectively, you know, like try to get this perspective, you know, when one of us will have this case tomorrow, right?
So usually we do a 6D, which means we first do rotation angiogram from the guiding catheter and then from the microcatheter. I wonder whether we should have done it from the ICA and from the VA, because then it would have been obvious that there are two different compartments. Here it seemed too easy, so we just went through without doing what we always do, and in retrospect, it's a pity we did not.
Yeah, what struck me and what I think it's a very simple way of understanding things is just to look at the dilution of the contrast. So if they were the same vessels, and you could see that from both sides you would have a large amount of blood coming in. Once they get into the same vessel, you would have a very high dilution from non-contrasted blood into that vessel. And that struck me that in both cases, both from the anterior circulation and posterior circulation, you would have a very nice and completely filled vessel, an artery, meaning that there was nothing coming into the same vessel from another side. See what I mean? So this is a
Absolutely.
simple.
I think you're right. This would have been, however, for a regular diagnostic angiogram with a 5F, these are things where we look at. When we do the procedure, we take an 8F, we inject a lot of contrast to fill everything. So usually we overcome with anastomosis, and it's filled much more to see everything. So with the 8F and hyperpressure injection, probably is less likely to be seen. But with a 5F, definitely.
Rene, thank you so much. I mean, as we analyze the case, right? Like for those that are watching retrospectively, there are so many signs, right? Like a couple of signs that something is off. And we're entering with the mindset that you're showing a complication. But the whole trick is to how to see this prospectively, and it's so difficult.
Yeah,
I
if you
think.
show this prospectively without saying it's a complication, it's very like what, right? It's the other thing is how this is in the level in the spectrum of complexity of the AVM you do. This is certainly like as you mentioned at the beginning, like an extremely simple one, right? And generally, like often personally, that's where I get into trouble personally, right? When things look simple.
So the
But
take-home message is not to forget that there can be more than one PCA. It's not frequent, but at least I will remember.
I can show if let me show a few seconds. I can show you there's in neuroangio. I think what's not it's like what's I'll show you the audience like what this is about because this really is the anatomical point is that there's a spectrum that embryologically the anterior choroidal artery we think uh, looking at Dodi, but we think that basically the choroidal and the PCA can share territory, whatever, however it is. Not getting into theory, but the bottom line is that when that happens, and that happens rarely, usually the choroidal only takes over the inferior temporal territory. That's the most common because that's the least sort of like invasive into the territory of the PCA. And then if it takes over more and more, that's more rare. So the occipital one that you showed is actually, I think, is very rare. I have only one case where there's like this. We saw this like in normal kind of anatomy, and this is what this looks like. Uh, Here, if you look at this page, this is the anterior choroidal page. And so essentially, if you go back here, um, you kind of see like this is what it typically looks like. Typically, you're injecting the vertebral artery, frontal view, and you see that on the left side, there's something here, and on the right side, there's this vessel is missing. You see that, right? You guys see that? So that again, it's not subtle, but it's also like we don't pay attention to that. But like once we recognize that, everything in angiography needs an explanation. Like there has to be an explanation why it's like this. Like it's not just like, yeah, whatever. There's a reason. And the reason is this. Like if you look at, I don't have, if I can look at this. So basically what the bottom line is that territory is coming from this vessel here, which looks like the PCOM and the PCA, but it's not. It's the choroidal artery. And the choroidal artery is supplying this portion of the inferior temporal lobe, and that's actually the choroidal part here. Now you can work, like once you suspect this, you can work this out. There's so many ways to work this out, right? Now here's that case that I was referring to is where you have basically, if you look at how this is the posterior communicating artery, this is the PCA, and here's the choroidal, and here the choroidal supply. You see how it extends down lower, and that covers the occipital lobe, and that's the corresponding vertebrobasilar injection. So anyway, go to this page and look at it in more detail, but that's kind of the part of that spectrum, and that's that wedge again. So also looking like this to see in this area if we're missing the calcarine branch or if there's something is up with that, that can help. And then there's that full takeover. So in this case, you have this big vessel, right? And that's the entire PCA territory from the choroidal. So basically, like it happens, like all of these things, we look at them and it's variations and it's nice and whatever, but like once in a lifetime, something like this happens and it becomes important in terms of what we do.
So there's a question, what would it have changed? By knowing it, it would have changed a very important thing, which is that a microcatheter would have been placed also selectively in the other branch from the ICA. And the goal is to see where the normal branch is and how far to push the TVE in order to occlude everything, but to keep the normal branches. So it's a way to get this under control, which we did not do here. We had less control, so that's why we had some ischemia.
Did you inject only from the vein or also from the artery?
Yes. No, 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 only from the vein. The microcasters are only to control how far you have to go. And indeed, the treatment by the vein is usually with lower risk of ischemia than from the artery. From the artery, you always kill more arteries than from the vein.
Yeah.
I mean, the type of complications, right? Like broadly, there's the complications that we expect and they happen despite ours being like aware of them. Like, for example, we're coiling an aneurysm and it ruptures even though we obviously tried not to rupture. But then there is the one that we don't expect, like this, like where we are like something happens and we didn't prospectively like control for that. And that's the more, I think, is the more treacherous one because we're not like we're I think less prepared for it.
So yes, 6D would have been fabulous to see it. It's just that I did not do it because the AVM was too small, too simple, and I rushed to the AVM. But it's the contrary of what we do always. So the only time we did not do it, this is what happens.
I mean, Rene, what do we
you think?
when we like to like there's the school of thought that says let's just follow the protocol. Like, like anesthesia, airplane, like we have checklist. Always follow the checklist. But we also don't, right? Because the head is everybody is different. So how to think of that? Do we always follow the checklist? What do we do?
But I mean, there's quite often situations where you see a PCOM doing also part of the job, and then the interest of doing it is lower, except if you think of the duplication. Otherwise, if the PCOM, if the PCA just comes from the PCOM, the interest of doing so is lower.
For sure. Any other comments? Any questions?
So, Rene, do you think during the fusion of the ICA and PCA or the vertebral artery is helpful for this case? If you did at previous day, maybe you can recognize this structure and then can avoid these kind of complications.
It would have been
I mean,
fabulous to have shown everything in retrospect before, and then it would have been possible to control and to avoid this. No doubt. So yes, we need more volume imaging for this too.
Okay, Rene, thank you so much for showing this. It's a great case. It's so instructive. Thank you. Okay. Dr. Wang, you're up next. Please, thank you for coming. Mingze Wang, can unmute yourself and share your case, please.
It's my turn?
Yes. Yes,
Okay.
thank you.
Okay, sure. Here is wait just a moment. Oops. I have to set my computer first and just a moment.
Yeah, take your time. While we're waiting, I think I can maybe show very quickly. We have a whole new section on the neuroangio dedicated to cone beam CT, and it's a project that involved many people, and we're still actively looking for contributors. Some of the people here contributed. Thank you very much for doing that. And this is really here. This is page. You could just Google it, comprehensive CT reference. Lots of stuff. There's like theory of how cone beam is obtained, the background physics and so forth, and then the practice, how to get the images for Icono, for Philips, looking for, GE. So really a lot of information. So thank you to all who contributed. And it's a resource for exactly what we do, because as Rene, as we discussed, like to go forward, to do better, to do more,
okay.
this is the next frontier.
So, sorry,
Okay, ready?
Shapiro.
Great.
I have come
Yeah,
back.
go ahead, go ahead.
I have set my computer right. Okay. And
Okay.
here's my point. Okay. Because I download the template from our official web in the Chinese mode, so I have done a bilingual PowerPoint. And here I share a case for application of flow diverter on multiple vertebral basilar aneurysms. And here's the basic info of the patient. Is a male of 73 years old with a chief complaint of intracranial detected 14 years ago with choking while drinking and unsteady gait for over 3 months. Hypertension history and taking hypotensive drugs regularly with a daily BP around 130 over 90 and with a medical history of 14 years ago, patient found a basilar artery aneurysm for approximately about 2 centimeters during an examination. And the patient was asymptomatic at that time and declined treatment. 3 months ago, the patient began experience choking while drinking without any apparent trigger, which has progressively risen, accompanied with unsteady gait. And the patient's PE was alert and fluent speech. Pupil were equal and round. The gag reflex was diminished. Muscle strength was grade 5 minus in the left extremities. And here is his outpatient examinations. Is contrast enhanced high resolution MR revealed multiple circular aneurysms in the left vertebral and basilar arteries, and dilations of parent artery, and the right vertebral artery joins in the aneurysms, but with not a very clear location. And here's the image here. And in fact, he has 3 aneurysms, the vertebral one, and the one giant one in the junction, and the third one in the trunk of basilar artery. And before the operation, we did a preoperative DSA. It shows the 3 aneurysms. And the patient's right vertebral artery was slender and could be seen, but can identify that it joins into the aneurysm 2, the giant one. But what about the pica is unclear. So with a primary diagnosis, the patient was with left multiple vertebral basilar artery aneurysms and a history of hypertension. And the giant circular aneurysm at the vertebral basilar junction is a giant one, is a symptomatic lesion whose mass effect compresses the nuclei ambiguous and the corticospinal tracts in the medulla oblongata, resulting in symptoms of choking while drinking and weakness in the left extremity. The reservoir effect of the giant aneurysm impairs cerebral perfusion, resulting in gait instability. And for this patient, is present with multiple tendon aneurysm from the left vertebral artery V4 segment to the upper middle third of basilar artery trunk. Among these, the giant aneurysm at the vertebral basilar junction is the a culprit lesion responsible for the current clinical manifestations, posing both of risk of rupture and mass effect. The primary object of our treatment is to address the mass effect and rupture risk of aneurysm 2. Given that aneurysm 2 has already caused severe compression of the medulla oblongata and pons, this procedure will be primarily involved with placement of flow diverter with minimally to no coil embolization to avoid exacerbating of the mass effect. And here's the legends feature. In the size, the three aneurysms separately sized 3 multiplied by 4, 31 multiplied by 28, and 15 multiplied by 11. And because due to the poor filling of construct on 3D reconstruction of DSA, we use the result of MRA. And with a rough assessment, the length of the parent artery is at least 67 millimeter. And here's another problem that is what about the PICA of the on the left side? So where the right vertebral artery join into the aneurysm, and what about the relation between the PICA and the inflow pathway? And here's our difficulty of our operation. The first one is the length of the FD. As we know, now we have the products we used very commonly is the pipeline with the largest one is 5 and 40, but the distance of basilar artery tip to the normal vertebral artery is larger than 67, and the diameter of basilar artery is bigger than 5 millimeter. So most available products are inadequate to meet the requirement. Should a single diverter stent be used to cover from beginning to the end, or should multiple flat diverter be used to telescope technique? And the second one is the sufficient support of the system. The tortuous nature of the vertebral basilar system, combined with the giant size of aneurysm 2, makes it difficult to achieve sufficient support during the deployment of the FD across the aneurysm 2 and its distal segment, which may result in a retraction of the distal end of the FD, and how to acquire sufficient support. And the third one is the occlusion of the right vertebral artery and its impairment of PICA. The preoperative angiography has not clarified the relationship between the right PICA and the right VA. If the distance from the influence zone of the origin of the PICA is insufficient to allow safe occlusion, how should it be managed? And here's our...
Do we want to stop and discuss, or should we continue?
Continue, and we can discussion later. Okay. And
Okay.
here, but I'm really curious about how will you to deal with this case?
Yeah, so should we discuss that now, or do we want, it's up to you, up to you, but I think there are already a lot of things we can talk about, based on what you already showed.
Mm-hmm.
Any comments, any questions?
My comment is that I have very low hopes of having any good result with anything we do in these cases. Of course, we tried with flow diverters multiple times, not very many, but because they never worked. I don't think we have a good enough solution for these cases. So I'm very curious to see where this case will end up to, because in my experience, we never had success.
Okay. Okay,
So
thank you,
I would
Professor Boccardi, and congratulations, you have guessed out the result. But I think our process is very excellent. So let's see how we deal with it. Okay.
I have one suggestion, and I think we'll talk about this later on, but I think one thing to me is important to say at this point, in that, as you mentioned several times, you recognized the limitations of the angiographic results, that despite doing the angiography, the relationship between the right vert and the pica and the aneurysm, we still don't know. You're basing your measurements on the MRA, which I think is correct, because the angiogram is really like not allowing us to do that. But I do think, in fairness, that an angiogram can be more informative, as you know. And I think and that depends a lot on one's like sort of setup and technique and everything. But I think the one thing that definitely helps, and I urge you to do that, is when you're dealing with such a complex lesion, that the angiogram should be done under general anesthesia. The diagnostic angiogram. I would consider doing that because it will allow you to, obviously, like a lot more that can be done. And I think the information that you seek, which is the pica, as you said, where the icas come from is also important. What the PCOMs are doing, other PCOMs, like all of this stuff, I think is improved by having general anesthesia. So that would be my one suggestion.
Yeah, I agree with you. Yeah, and because the preoperative DSA was performed with the local anesthesia, so the image was not very clear. So maybe in the cases like this, in the later we'll do it in another way, and here is our process.
Hold on, Rene also had a comment.
Okay.
Yes, there's one point that strikes me. The reason this patient was not treated before is that somehow he did not want a treatment, but the main factor was that the aneurysm was asymptomatic. Which aneurysm do we wait for to be symptomatic before to treat? Do we wait for an ACOM to be symptomatic? Do we wait for a parophthalmic or a PCOM to be symptomatic? In fact, when we don't want to treat, we use other arguments saying the aneurysm is not symptomatic, but none of the aneurysms we usually treat are symptomatic. And it's a way to delay. And I fully agree with Dodi that the chances of treatment are low or very small, but there's one additional comment I can do to this, which is the larger the aneurysm, the less treatment works. So I think that the fundamental errors that 100% of us do, is not you, it's not me, it's everybody, is that we wait before the aneurysm gets bigger. We wait for the small tumor to get a large tumor, and then if it's a large tumor, we try to treat and we say our treatment is not efficient.
Yeah, thank you, Professor Chapot. And for this case, the patient 14 years ago, when he found this aneurysm, he was afraid of the complication and the risk, and still refused to receive the operation. And now he gets aggressive compression effect, and then have the decision to face this problem. Yeah, and here is our procedure.
Hold on. Also, Vittorio had a comment, but now he disappeared. Vittorio?
I'm here. No, I wanted to say that actually I totally agree with Rene. I mean, these are lesions that we usually don't consider for treatment. Once, even if symptomatic in this moment of evolution of the disease, because our chance to be successful, I mean, in our experience, are really, really, really low. I would say almost zero. But at the other side, if we take at the beginning, we have more chances. Rene showed is serious, and I wanted to say something about because Max pointed out the general anesthesia. I would point out also the field of view. I mean, it's very big compared of what we usually do. We like to have bigger images, and here you have all the neck, and maybe it's not so useful in the planning during the angel just for the technique. We focus really on the field of 22, and it's allowed to do a better planning for the for the measurements and whatever. So
Okay, thank you. And I also have a question for Raz and Shapiro, because you are the specialist of compensity, and is is an image that performed with the angiogram, and for this kind of giant aneurysm, which have a very critical reservoir effect, how can we keep very clear 3D reconstruction result in the cases like this with the techniques that our angiogram machine can do?
I missed that if you show a 3D, I missed that. So I don't know how you did it, but when you have a large aneurysm, the delay has to be longer, right? Because you need more time to fill the aneurysm completely. And now another problem is the inflow, right? If you have a codominant vert or you have significant inflow, you need to increase the flow and to increase the delay. So you give time from your site of injection to like feel like the contralateral. So with more flow, you're gonna feel the contralateral and push against the inflow, but you have to add delay. So those are things that can improve with your injection metric, can improve the quality. But anesthesia is another part of it. Another thing to consider is the use of really, like here we're trying to get important information to decide the strategy. So as much as it can sound aggressive what I'm going to say, in the long term of when you deal with something so complex, is actually like something to consider using a balloon, meaning you have two micro catheters. You inflate with a balloon your inflow from one catheter, inject from the other side. Something that may sound crazy if you say, oh, this is just an angiogram, but when you're dealing with something so complex, I think those are all important. If that's necessary to obtain important information, I would say do it.
Okay, great. Good idea. I will try next. Okay, later.
Yeah, I just wanted to add two things. So first, in a few weeks, we're going to have our Bananas China edition, as you probably know. And we will have a presentation actually on cone beam CT. So with this in mind, we're gonna like show some we have some cases, so we'll show you like more specifically how to get good images for a case like this. Okay, so I think we'll follow up on that. The simplest way of doing it is basically with the patient under anesthesia. You take the vertebral your diagnostic catheter kind of higher in the vert, in the more dominant vert. Let's say in this case you have the dominant vert on the left. You inject, and during the DSA, you see how long it takes to fill the whole aneurysm, right? You count from the time of injection. Say it takes 5 seconds from the injection to fill the whole aneurysm. It's going to take a long time. That becomes your delay. So that becomes your delay during the cone beam CT, and I think that works well.
Okay.
So that's but we'll go more into this later.
Okay.
Niwei has a question or a comment.
Yeah.
You have to unmute.
Yes. I just want to continue our previous topic about the timing of this kind of treatment. For the actually our team, we have an internal discussion always have about these kind of cases, like the large dissecting aneurysms of vertebral artery, or like the VBD, or such complicated cases. Is a symptomatic time is a right time for the treatment? This is always very controversial, because for these kind of cases, based on our experience, the success rate is not very satisfactory. Actually, 50% of the cases maybe have a good outcome, and maybe 50 have a bad outcome. So if the patient have no symptoms, at this time we treat. If there is some risks or the complications, we cannot endure. So for us, we will wait for the patient turn to be symptomatic, and then we treat it. And at that time, no matter the outcome, and the patient and the physicians as well can tolerate any kind of outcomes. But if the patient is asymptomatic at that time, I will not treat as well. So I don't know what's your opinion about this.
Wait, I
Yeah,
think
yeah.
the
Okay.
the
Yeah,
difficulty we can talk about, I mean, I don't think we're gonna solve like right, it's not gonna solve this problem today. But to me, the problem is that even in the asymptomatic, I completely agree with Rene. Like it's like, Nicola Machiavelli said this about many years ago, like how medicine is like other things. Like by the time the problem is obvious, it's often beyond solution. It's when the problem is less big that maybe its solutions exist. But I think to me, the problem is that for this particular aneurysm, even in the asymptomatic stage, as Wei said, like the complication risk right now is very high, even in the asymptomatic ones. So where I hope we can make progress is in better treatments at the asymptomatic stage, so that we can maybe offer patients like a more palatable, like better alternative for this. And I think Rene showed his series of like using bigger devices and so forth, like making progress in that.
Yeah, I think Professor Ni have raised a very great question, and I think it's not a medical question but also an ethic question. Yeah, so I think maybe we should obey the indication of every disease, and then it depends on the patient's determination. For this patient, maybe he better have done this operation 40 years ago. Maybe he might have a very good result, but 14 years later, the result changed. Okay, and should we go on our case? Okay.
Yeah, let's continue.
Yeah, we have used a lot of materials. The list is here, and we have used the long sheet, the distal access catheter, diagnostic catheter, and macro catheter guide wires. This is the normal guide wire and this macros. And the FD, we used a Chinese one. It's the largest one maybe in the world. It have a 6 millimeter in diameter and a length of 70 millimeter. It is adequate to this case. And here we use the balloon. Why we use this, we can see it later in our slides. And a coil for the occlusion of the right vertebral artery. And here's our list. And here we go. Let's see this. At first, we used 8 Fahrenheit sheet, established a transfemoral pathway, and the long sheet was advanced to the origin of the left vertebral artery, with a deck placed at the origin of the V2 segment. Here is the deck, and then we trans the deck. We delivered single 2 macro guide wire arrived at the P1 segment of the left PCA, and during the advancement of the vest tube is a macro catheter. It was noticed that exerting the significant press on the wall of aneurysm 2, this one here, which indicated suboptimal system stability. And DAC was planned to be advanced as distal as possible to ensure safe deployment of the FD. So here, we deliver another system of microcatheter and macro guide wire, is Synchro 2 and echelon through the DAC to the same position of PCA. And in this dual technique, we have advanced our DAC through the aneurysm 2 and reached the aneurysm 3. And in this position, when we deploy the FD, it will be much safer because here we have a very strong support. And yeah. And then we delivered the FD system was successfully delivered through the Vestube 27 microcatheter to the origin of P1 segment of the left PCA. And here is the beginning of the stent. And here is his gateware. And here is echelon. Here is the Synchro 2 is together. And here is the deck. And here's another problem, because this position have a lot of pressure on the wall of the aneurysm. We think it's not very safe. So how can system retreated be avoided, and the pressure on the aneurysm wall be minimized during the subsequent push and deploy process of the cobalt chromium FD? You know, our FD was the cobalt chromium, so it have to be pushed during the deployment, and it will be a lot of pressure on the wall. So here we made a safe tether. How we made it? The Synchro 2 and the echelon 10 assembly served as a safety tether. Here, anchoring at the basilar artery posterior PCA by leveraging the pressure from the distal end of the FD. It means we use this FD partly deployed and put the Synchro and the echelon under it, and to squeeze it on the wall of the basilar artery, and then it can provide some force to drag the deck and to keep the right direction when it was retreated here, when we deploy the FD here. Because we use our machine do not have mounted the record system, so we have to record it use our DSA machine. It can only record the latest 300 frames. So a lot of process were missed. And then with this technique, we have successfully deployed our FD into the Aneurysm 2, and we have withdraw our deck here, and keep our safe tether here to with a drag force of the deck. And when we have deployed all the FD, we withdraw the safe tether. Yeah, here's a distal part of FD, and here's a proximal part of FD. And after a massage with Synchro 2, this distal end of FD slightly retreated, but was still beyond the aneurysm 3. However, a kinking here was observed at the proximal part, resulting in a very severe stenosis. The echelon 10 could only be passed through it with difficulty, while the Vestube 27 could not be advanced through it at all. And we planned to use a balloon system to make it dilated, but it cannot pass the stenosis. So a harder massage method was required at that moment. And after carefully analyzing the direction of the twisting, we attempted to use a guide wire, the 0.035, that one, to rotate the proximal end of the stent to resolve the twisting. And the Synchro 2 and echelon 10 was delivered into the FD to stabilize our system. and the deck was advanced into the flare end of the FD. Here's the deck, and here's the FD proximal part. Yeah, make it into it like this, like a mid-air refueling. Yeah, this is our deck, and this is our FD. And this method to ensure the guidewire smoothly reaches the inside of the stent to avoid stirring the stent's distal end and make it unbraided. And after our try, yeah, here's we have make it through. Yeah, you see the stenosis, the twisting was resolved and is much wider. And then the guidewire successfully resolved the stent twisting, and the patency within the stent allows for the passage of the balloon system. We use a gateway 3 multiplied by 15 and dilate the twist segment to a satisfactory degree. Here, until here, our treatment for this aneurysm through the left side was completed. And here is our follow-up angiogram. Yeah, and we found that the distal end slightly retracted again, but remain in the position within the outflow tract of the aneurysm 3. So, and next we will deal with the right side. We set 6 Fahrenheit access through the left femoral artery and use MPA1 angiogram catheter, diagnostic catheter, advanced into the vertebral artery. And because the artery is very thin, so we do not use a guiding catheter. We delivered Atrin 10 through this diagnostic catheter and reach the end of the vertebral artery and see clearly where it ends and where the pica originated. And here we have a relative enough segment length for a safe occlusion. So we use a coil to make it occluded. And we do not make it reach the original part of the pica because we think there is more thrombus will happen here. So if we coil it to here, it may be occluded. And we see from this the blood flow through the right vertebral artery to the aneurysm was almost diminished. Yeah, here's the post-operative angiography, and here's the AP view of left vertebral artery, and here is the lateral view of the left vertebral artery. So here comes the post-operative status. The patient complained about blurred vision after the operation on that day, and administrate the DAPT with aspirin and clopidogrel, along with controlled hypotension to prevent hyperperfusion. And on the day 3 after operation, the patient complained about double vision, left side facial weakness, choking while drinking, and numbness with weakness in the left limbs. And the PE revealed alternate with fluent speech, limited left eye abduction, flattened left nasolabia fold, tooth showing deviation to the right, and the left side muscle strength graded at 4. And we consider about we think that caused by the aggravated mass effect of aneurysm thrombosis and the muscle strength elevated after the administration of mannitol, and 4,000 units of LMW low molecular weight heparin was used to slow the rate of thrombosis within the aneurysm and prevent the occlusion of the perforating arteries. And here we performed several CTs after the operation, and here is the operating day, and the day 3 after operation, and the day 5 after the operation, and you see the top part of the aneurysm 2, the CT volume, CT volume have raised. Yeah, the day 1 is 41, and from the day 3 is 72, and here is around 70 is the volume of thrombus. And here the other part is in the middle and the bottom part of the aneurysm 2, and from the and in the ventral part, it changed like this: 43, 42, and 75 on the day 5, and the dorsal part have its thrombosis more faster. On the day 3, it has reached 76, yeah, and it demonstrated a satisfactory thrombosis formation within the aneurysms, I think. But on the day 5, the patient suddenly lose of consciousness and weakness on the left extremities, and the CT scan revealed intracerebral aneurysms, hemorrhage on the right thalamus, and broke into ventriculars here. And his legal guardians rejected further treatment and decided to abandon treatment, and the patient died in 3 days. And we have analyzed the causes of this issue, and we think that the result of the reperfusion-related hemorrhage may be the cause, and because the Resolvac effect released due to the FD, and blood pressure fluctuation were observed during some perioperative procedures, especially when the airway care. And the second reason we think is antithrombotic related hemorrhage, because the patient is receiving DAPT and the anticoagulation treatment. Both of them increases the hemorrhagic risk. And in this case, we think we have 4 points we have concluded. For 2 points in the operation, for the operation, we think that adequate system support is prerequisite for successful deployment of FD, particularly for those made of cobalt chromium alloy. Increase involving giant aneurysm and parent artery reconstruction. The dual track technique can facilitate the successful conduction of Trojan horse technique, while the safe tether helps reduce the tension of the deck. And another one is for the twisting of stent. During the deployment of an ultra-long FD, the accumulation of twisting force increases the likelihood of twisting. Massage via microcatheter and microgather or balloon could solve most of this issue, but in some special circumstance, maybe some unconventional method may be flexible employed. If the twisting is unavoidable, efforts should be made to ensure it occurs at the proximal end of the stent, so you can have the chance to resolve it. And for the perioperative management, we think that remote side hemorrhage is still a problem in FD patients. We have several patients suffer from this, and some of them are lucky and lived, and some are dead. Despite dynamic monitoring of the platelet aggregation function and the coagulation index, while the patient was taking the DAPT and LMWH therapy, the patient automatically died due to the thalamic hemorrhage. Hyperperfusion and antithrombotic therapy might co-work on this outcome. The risk of reperfusion and antithrombotic hemorrhage may require more individualized assessment too, and discuss on this topic are welcome. Maybe I can have some suggestions from all of our experts about this. And the second one is the presence of pre-existing mass effect was primary reason for the opting to use a flow diverter stent alone in this case. However, the patient still exhibited signs of aggravated mass effect, but also maybe include some contributions of preparator-related remains. For giant aneurysms in the post-circulation, how can mass effect be more effectively alleviated to prevent its exacerbation? How can mass effect be rapidly distinguished from preparator events to enable timely and effective management? This remains open question for discussion, and the suggestions are welcome. Okay, here's my presentation. Thank you.
Thank you, Mingze. Thank you very much. Another complex case. Okay, there was some discussion in the chat while we were presenting. If you could take a look.
Okay.
Max, maybe you could unmute and speak up. There's a question about adjunctive coiling and a few other things.
Yeah, thank you for presenting it. I think these cases, we keep on repeating them over and over at multiple presentations, right? And complication courses, and nobody seems to agree what's the best technique. But I would argue the consensus, these giant ones, we don't want them to clot too quickly, because when we see this rapid change in density of the clot, that's a worrisome sign. And I would argue that having adjunct coils here would stabilize this, hopefully, and preclude this massive thrombosis and expansion of the hematoma within the aneurysm. So I'm curious, Dr. Wang, if you considered using coils once the flow diverter was deployed, as an additional frame, and what are your thoughts on using triple therapy? We've been doing it routinely with adding an anticoagulant, sometimes a full dose or a half dose for the first month, again to slow down the rapid thrombosis. This seems to be the reason why the aneurysm ruptured within the next 5 or 7 days. Thank you.
Okay, thank you. So, Professor Mokin, do you have any method to assess the risk of hemorrhage for this patient using both DAPT and the anticoagulations?
Well, it depends. I'm not sure I understand which risks you're referring to.
I mean, do you have any lab examinations or some scales to measure whether the patient is in a high risk of hemorrhage or in a high risk of ischemia?
Well, the DUAX, we don't measure anything. Aspirin and Plavix or aspirin clopidogrel, we can certainly measure it, but with aspirin and novel agents, mostly just a measure of compliance, if anything. Again, I think what are the potential risks here? The big one is risk of perforator occlusion, right? So multiple flow diverters or very densely packed coil would put a patient at risk of perforator occlusions. And I think a prior comment that a common cone beam CT would be very helpful, just understanding where the perforators are coming from. The intact basilar close to the junction with the aneurysm. My understanding here, what happened is the aneurysm was clotting very rapidly, And we have a couple of case reports. Adam Arthur was showing one. When the aneurysm clots very rapidly, there's a layering of the clot, and then there's just tears on the wall of the aneurysms. And that's what happens. I missed the picture of the type of a bleed. Was there a rupture, or did I miss that?
Yeah, it's a symptomatic hemorrhage.
Yeah.
Here is in thalamus, not in the aneurysms. Here,
It's where exactly?
Yeah. Yeah, so I think it's a remote hemorrhage, but not a rupture of the aneurysm.
Can you show the posterior fossa, please? So you don't think the bleed expanded from the wall of the aneurysm higher up into the ventricle? Because
Yeah,
it's mostly an intraventricular hemorrhage.
Yeah, because I think the third and the fourth ventricle was relatively clear, and here we see it in hypertension hemorrhage, very common that it happens here and then
I see.
to the ventricular and then to the third one.
Yeah, right there. If you stop at the low
You think
thalamus,
it's a thalamic bleed that just blossomed?
that's right.
I see.
Yeah.
Well, but I mean,
Yeah.
you use dual antiplatelet therapy, correct?
Yeah. And my question is, yeah, we have thought of many methods to decrease the risk of the rupture of the aneurysm after the FD. Yeah, especially for the giant one. Like to very strictly control the blood pressure, and in some cases we coil them, especially for the in the inflow track to make it the injection weaker. And but in this case, I have about 3 cases with remote hemorrhage. So I'm very confused about that. Yeah, so I want some suggestions from all of our professors. Yeah.
Yeah, I mean, you could be right. It could very well be, but again, sort of the counter argument that even on dual antiplatelet therapy, the patient bled from something. So, I would still question whether this was initially an ischemic event, be that even a small thalamic stroke, and then it progressed into a hemorrhagic. Even with that case in mind, I would still worry more about ischemic complications as the primary reason for things to go wrong, rather than over anticoagulating the patient. I wonder what others think, but that's a very good point. Thank you.
Okay.
I missed that.
Okay, thank you for your comment. Yeah, Professor Chapot.
I mean, thank you for showing this because it's always painful. We stopped using flow diverters primarily in those aneurysms. Even if it's a large one, there are even larger ones. You just mentioned before it was a large one. Indeed, I think in many countries, the Derivo is also available up to 8 millimeters, so even more. And they all carry the same problems. The longer the flow diverter is, the more there are issues of properly opening. But we stopped using flow diverters primarily in those patients because the rate of complication, either of bleeding or of ischemia, is much higher because you do not control the speed of thrombosis. And giving some heparin, nobody knows how much heparin you need to give to prevent it. Primary treatment with a braided stent induces slower thrombosis. This is completely subjective. Slower thrombosis does not mean that problems don't occur, but the faster the thrombosis, the more problems. And that's why the debate on coiling is also highly subjective. Of course, not too many coils, but you want one thing and the contrary on the same time. I'm not sure. I think that the less dead space, the less issues. And less dead space means smaller aneurysm and larger device. If a device is even able to go around the curves of the arteries, what do you want? You just want this aneurysm not to grow. I mean, shrinkage is a bit inaccessible. You just don't want this to grow. And if we have something which is able to incorporate in the vessel wall and match to the vessel wall, then we should be very happy of it. And I must say that some materials are existing in that sense. It's not perfect, but at least the results seem to be interesting with either the Leo, but it goes only up to 7, or the Acerorex that goes up to 10 millimeter. So you can use it up to 12 millimeter arteries. But then it turns again that probably the worst thing here is to let the aneurysm grow. And what we don't do in those patients is that they don't get regular an MR. And even if you do one MR from one year to the other one, you see it's faintly different. But if you compare after 3 or 4 years, you will see it growing, and you know that they will die because of it. So early treatment, point one, and second point, braided stent. I mean, super large braided stent before potentially adding flow diverters. But if the thrombosis occurs slowly, then you can always flow divert.
Okay, thank you. Yeah, I'm very impressive of one of case of you showed us last year, and it's a patient with a very large carotid artery aneurysm about here in C1 segment, and you implanted a Leo and only a Leo, and then it got cured. Yeah, I'm very impressive about that case. Yeah, it is the contribution of the braided stents. Yeah, so thank you.
And Mingze, thank you so much for showing this case. A lot of learning points, a lot so we can maybe talk about that more in our upcoming bananas as well. Very difficult. Thank you. Okay. Next up is Dr. Heng Yang. If you can, if you see, let's see if you have a case as well. Do you want to show a case? If you do, unmute yourself.
Okay. Okay. I share my screen. So this case is a complex AVM. And right basal ganglia alveolus malformation. And this case is a 27-year-old female patient presented left side paralysis and blurred in the left eye for 2 weeks. And the fixed examination shows the mask strength is grade 3 in the left extremities, and the left side basking side is positive, and the past medical history is negative. And so the CT scanning, we can see the high intensity lesion in the right basal ganglia and thalamic and the pinna region. And the CTA, we can find the right basal ganglia AVM, and with the dilation of the draining vein. And this is the MR scan. We can see the flow void signal in the right temporal lobe and basal ganglia, and with obvious surrounding edema. And this is T2 flare. And this is a follow-up for CT because the patients have presented progressive version of the left extremity paralysis. And so we follow up the CT scanning and find the there was enlargement, obviously. And this is compare between the CT scanning and we can find the venous various enlargement, obviously, in the past 2 weeks. And we performed the angiography, and this is the right side angiography, IC angiography. We can find the right basal ganglia AVM and supplied mainly by the lenticular straight artery and the right anterior choroidal artery, and the drainage to the basal vein and to the straight sinus, and with the obvious dilation of the draining vein, and also I could find a large venous varix. This is the right EC, and no blood supply for the AVM. And the left IC angiography and show the IC supply to the AVM from the anterior communicating artery, and left EC. This is the vertebral artery angiography, and we can find the right PC also supplied to the AVM. So this is a three-dimensional image of the right IC and the right vertebral artery. We also performed the combi CT and of the right IC and find the AVM was mainly supplied by the perforating branch of the right MCA. And I can find the dilation of the draining vein, and we also have a very large venous varix, and the varix was enlargement recently. So these patients have high risk of a rupture of the AVM. So the pre-option diagnosis is the right basic angular arteriovenous malformation. And I will ask the professors, and for this case, how to treatment. As we know, this is a very complex AVM patient cases, and it's difficult to achieve the curative therapy. And maybe we can choose the embolization of the AVM and from the TAE or TV, or combined with the TAE and the TV. And the patient also have massive mass effects. So we can cure the resection of the AVM or to embolize the AVM, and then to perform the stereotactic radiosurgery. So this is the case I want to discuss, and all the professor and the experts how to treatment for these complex AVM cases. Thank you.
Thank you, Heng. Any questions or comments? I'm Michihiro. Michihiro was suggesting in the chat transarterial embolization possible. Heparinization to avoid thrombosis of the, or too much thrombosis in the varix, I assume, right, Michihiro?
Yes, thank you very much. A very difficult case, and I think that the problem is such a short period of time, the varix either progressively enlarged, but not yet ruptured. So the clinical symptom of this patient is closely related with a perifocal edema surrounding the varix, extensive of varix. So we have to control not only as a nidus of the AVM, but also intravarix aggressive thrombosis. But without embolization, it's difficult. So we try to reduce the flow. We don't need to eliminate 100% of this very aggressive type of AVM, but just flow reductions and anticoagulations and wait and see what's happened on the perifocal edema.
Rene, yes.
I would like to know where exactly the venous aneurysm is. I'm missing information, a lot of information here. I cannot treat an AVM today anymore without a 6D. I need to know how are the primary veins joining the main one. Is there a way to point one go beyond that aneurysm? Because forget that aneurysm to be treated. The aneurysm is decompensating, but the key point is to treat the AVM, and I would politely disagree with Michihiro. If you can cure it, it's better. But how to cure it? It requires to be able, by the vein, to go beyond that venous aneurysm. And probably it's possible, but of course, this imaging does not even able to see. But if you looked at the size of the AVM itself, it's not so large. I mean, the veins that are around it make it look super large, but the level of the shunts is a really very reasonable size. And the chance to get it is, I think there's a high chance to cure this patient, but it would be better first to find a way to reduce it. I wonder whether some anterior branches of the superior MCA may allow to get access. I'm not sure, but potentially. Otherwise, if there is no arterial access, a stage transvenous by finding within the AVM if there are some primary veins that can isolatedly be accessed to get part of it. And usually there's a way, but without seeing those images, it's difficult to know.
So Rene,
Thank
could you
you.
please share us how about the detail of how to do these kinds of image?
I mean, you need MPRs and you need to find a way to put colors inside the MPR. So I would take a microcatheter, try to get each part of it. How to get each part of it? And can we see again the run of the ICA?
Yeah.
Yeah, I agree that, we need
Slowly. Okay, stop. Okay, come a bit back. So here in this location, you know that you always have transmedullary arteries from the M2s. They are tricky, but they are accessible. I'm sure that before it comes to the same vein, the vein itself comes from some primary veins coming together. The so-called nidus are veins that are all joining. So whereas those veins, by looking at the shelf, what we do, we look at the Trojan horse from outside and we say we see nothing. We must see inside. So seeing inside means MPR, but MPR monochrome is not so simple. So you may do, for instance, the first rotational angiogram from the ICA, and then put a balloon at the distal M1 and do another rotation angiogram so that you will have only the lenticular striates. This will enable to differentiate both and you will see much more. There is a way to make a dual imaging. Is there something coming from behind? I don't think so. Posterior circulation is here, not really contributive.
No, there is, Rene. Can we show
Okay, there
the
is.
images
So,
of
okay, so you may do this.
show the images of the vert injection, please.
But what looks big here is the venous aneurysm. The whole AVM is not so large. But yeah, that's small. This is something that you can get. You can get one feeder and do it, but it will not change significantly. So probably a first rotational angiogram. Probably it's better to have a cement system because it's more prone for this type of fusion imaging. Philips can do it too, but Philips works on the whole signal. So quality of the images you see when you have fusion with Phillips is not at the same level.
So you mean you will put the balloon in the distal NCA and then
Yeah.
inflate the balloon and do the angiogram? Yeah, right.
We presume that all feeders come probably choroidal, lenticulostriates, and transmedullary. If you want to differentiate transmedullary from lenticulostriates, you repeat another volume imaging by inflating the balloon in distal M1.
To add some more confusion to the poor Heng, I would propose something even different. I think that you need to do something urgent because this is growing very rapidly and something might happen quickly. So my idea would be to go transarterially and try to embolize as much as you can from the perforators, from the middle, from the lenticulostriate, in order to just decrease the flow. And so by decreasing the flow, probably releasing a little bit the tension, which is probably what Michihiro was saying before. And once you've done that, you might also think about radiosurgery, which is, the usual location for radiosurgery is pretty much that. So why not just start to decrease the flow inside the AVM? Because this is it might be a small AVM if you think so, Rene, but it's certainly a high flow AVM. You have a very big vein going all the way back to so that means that there's a lot of flow in there. And so you might just reduce it by going into the lenticular striate and try to just glue some of these vessels. And then whatever is the outcome, hopefully it's a good clinical outcome, then you might rethink of what doing. You could go venous if that's what you like to do, or you could also think at radiosurgery.
Do you have some imaging where the vein is to be followed more, against the flow beyond the aneurysm? Okay. Do you have some MPR images when you did the rotation angiogram? On the rotation angiogram, also what you show, we have only the arterial phase. The pictures that were just on the screen. Can you come back? One before. The 3D reconstruction you showed.
There were some good
we did
coronal NPRs.
Here you can see
let's see the lateral. The lateral of the ICA injection.
Okay.
Of the right ICA. Yeah, now go back.
Yeah, because venous outlet of the more distal to the buttocks are there any stenosis and
No. Yeah. For this case, we did not do the MPR actually. But Michihiro, do you think using the microcatheter injection of the closed limb CT is helpful for this case?
Can you show the lateral view more venous phase on the ICA? Lateral.
No. That's that page. Go back one page.
Okay.
Okay, now look at the lateral. Look at the lateral. Now, wait. Stop.
Yes, stop.
Yeah.
Okay. No. Yeah, stop that one. Stop the lateral. Now go back. Yes,
the venous phase. Yes, good.
Okay.
It's too early.
A bit later.
Venous phase, please.
No, yes. the other way. We want to see veins, so keep going. No, forget the frontal. Don't touch that. Go to the lateral.
For the lateral.
Go to the
lateral.
Lateral.
Now go more later to the vein.
Yes,
keep going.
Venous phase.
Okay.
Stop. That's it. Okay. Now go back. Go a little early. We want to see how the vein fills. A little bit earlier. More earlier.
So for me, this aneurysm is very distal on the course of the vein.
Yes.
And,
are there two veins, Rene, you think? Are there two veins?
No, we just see
One.
one, and the small veins inside we don't see here. So we
Yeah.
need a rotation angiogram, but which is done with an injection starting several seconds before during the rotation. This is a point, something I wanted to point out. When we see the 3D reconstruction, we only see the arteries. We don't see the vein. And in fact, what we're interested in is both arteries and veins. So that if you want to do a rotation angiogram from an AVM, the injection must start a couple of seconds before. Otherwise, for half of the rotation, you have the arteries and not the veins.
So we'll review this in our banana China. We have two things that already we know we need to review. One is how to do the big aneurysms, and one is how to do the AVMs. But the point is the same, right? When you're doing cone beam, your rotation is long. Like it's too long to separate arteries and veins. So you want to fill them all. Like you're not looking for dynamic information. You're looking to have everything, arteries and veins. And then from the 2D, you get the information about the dynamics. I have one question I have is based on the images that we have, I suspect that the contribution from the posterior lateral choroidals type vessels may be more than it looked on the 2D, because the 3D looks like there is more supply there. So maybe that's another target for transarterial embolization. Because I agree with Dodi, like right now, given like everything, like we also don't have really the experience to do like this advanced transvenous imaging or treatment, what I meant. So what can we do transarterially to reduce the flow, and then, gamma knife the rest is one, like I think one way to go. But the reduction of flow, I think here is important. So like just to do the gamma knife may not be enough, because you see how this varix is expanding. But there may be something you can do also from the posterior circulation, potentially, to reduce the flow.
So our current strategy for this case, because we have an internal discussion of this case, and our strategy right now is to let the patient receive the gamma knife at first, and then we will then come back to do the embolization. Because our gamma knife team said they maybe will injection of the honest will cause some artifacts for them and cause some confusion for their targeting. So they will do the gamma knife at first, and then after the procedure, maybe 1 day, 2 days after, then we will do the embolization. And we try to perform the pressure cooker technique via the posterior choroidal artery, and wait and see what will happen.
I think we've done the same. We've gamma knifed and then come back like a day later to do this.
Yeah.
The important thing here would be that when you are in the posterior lateral choroidal, you do a microdyne or microvasor CT, right, for Phillips. Like inject through the microcatheter from the position that you're going to deliver onyx to see if there's any supply to the thalamus or any brain. Because that's really how micro, like cone beam CT can really help you. You do that, and then you see if it's just like, it's not 100%. You could still like flow and all these things can still mess us up. But it gives us more information, and I think a lot of times it's very helpful to do that. So I would suggest doing that, and they gain experience with doing micro injections. It's usually by hand. Typically, the person stays in the room. You start injecting like 2 seconds or so before, 2-3 seconds before. Then you do a single spin, and then see what you can see.
Sure, thank you.
Max, just a crazy comment. If this was a CC fistula, you would argue you would drop 3 flow diverters and try to slow it down. Would you ever consider dropping a couple of flow diverters to cover the M1,
No.
hoping that you would slow it down?
No, that's crazy, as you said.
No. We don't honestly, I mean, we're not, we love flow diverters for a lot of things, but for CC fistula, I'm not sure how they work. But the problem is, of course, you jail yourself out of all these branches.
Yeah.
So those M1 branches are can be difficult, right? They're tortuous and they can also supply brain. So if you are in those, guys, if you're doing this, like this AVM personally, and I, of course, like vastly less experienced than Rene. And so in part, like I'm just worried. And so every microcatheter position, unless I'm very sure, I do a micro cone beam and see, especially like in that at the base, like there could be basal ganglia, hypothalamus, whatever, all these areas, right? So micro injections, I think, help a lot.
So, okay.
Yes, Matt.
Does everyone think that this case should be treated? Yeah, because in this presentation, Dr. Yang mentioned that he performed this procedure because of the enlargement of the venous aneurysms, right? It makes him think that the lesion is in a very high risk of hemorrhage. But here I will show you an article that I have read last year, and if I can share the screen.
Okay.
Okay. Okay, here. This one. Yeah, it's also a work by my colleague. Yeah, it's published on the JAMA network. And in this article, they built a scoring system to assess the hemorrhage risk of the AVM. And in the factors included in this article, here we see they mentioned that they think that the venous aneurysm is a protective factor for the hemorrhage of the AVM. Yeah, so in this case, maybe I think I will partly agree with Dr. Ni's idea that perform the gamma knife first, and then to looking for the chances for the further treatment. Yeah. So and what about your think about this article? I think I know you will think that is impossible. Why a very obvious risk factor could be a protective
factor.
Yeah,
I mean,
yeah.
the way I interpret it is that if there is a venous aneurysm, it's an
Mhm.
expression of the venous system able to sort of like increase the capacitance, right?
Mhm.
So in a way, maybe this is an expression of this venous system able to, you know, compensate enough, right? If there was if the venous system is not able to compensate, would bleed, and so
Yeah.
maybe that's how it to interpret it.
So in our daily work, we think that two factors is the indication of the hemorrhage. One is the intranidus or extranidus aneurysms in the arteries, and another one is the stenosis of the veins. So maybe in the cases like this in our hospital, we will do not very positive to perform the endovascular or the microsurgical operations. Yeah.
I think it's an interesting point, Mingze.
Yeah.
I agree. Look, I agree that in our experience also, like the risk factors for rupture, and that's literature. Intranidal, perinidal aneurysms, yes, arterial. Single draining vein is a risk factor, consistent. One obvious, like it has to make sense. So this makes sense, right? And as you said, stenosis. Now, I will say this, that in this particular case, the reason I support treatment is because rupture is not the only problem that the AVM comes with. Like we think rupture, but there are many other issues. Like this patient is presenting with mass effect. So I think from that perspective, I think treatment is reasonable.
Yeah.
Because it's hard to see how this is going to get better by itself unless we do something.
Yeah.
But yes.
I think in this case, any treatment, any surgical endovascular treatment will cause the complications not better than the present status. Maybe.
High risk. No, high risk. high risk. So I think so that goes back to the vaso CT. So how to make this lower risk?
Yeah, yeah.
Like, okay, gamma knife, I agree, gamma knife, but what about the timing, blah, blah, blah? Like, should we try to reduce the flow? I think the way to get to lower risk treatment in this type of lesion is through more advanced imaging and understanding where we are injecting, right? So that's the way to go, but definitely it's not, it's a high risk lesion.
Yeah,
High
yeah.
risk lesion.
And I have another question for Professor Boccardi. Yeah, he mentioned just now that to partially embolize the lesion first, and then to reduce the flow, and then to perform the gum knife, right? And for this kind of lesion location in the very critical area, eloquent area, how do we decide which part to embolize first, and which part to leave to get to left for the gamma knife
No.
and to reduce the complications of the extremity movements or something. Yeah. Will you to combine with some functional images to decide which part to embolize and which part to
No.
reserve?
Stop. Much more simple. And first of all, I agree completely to do gamma knife before, but you have to do embolize as soon as you can, meaning that you can do it the next day. I thought not to. The idea is not to do gamma knife and then wait for months to see what happens and then do something else. So I certainly in the recent years, we have certainly preferred to do gamma knife before in order embolization in order to avoid all the artifacts or non misunderstandings once you have some embolic inside the AVM. So it's better to do it before. But then my point is to do to embolize as soon as you can because I think that the AVM is not stable at this moment. You have edema, the aneurysm, the varix in the vein is stagnating. It's not normal flow inside it, but it's the flow. The contrast is stagnating inside it, meaning that it doesn't look good. So I would certainly like to diminish the flow in that AVM. How going into the feeders, and the feeders are mainly the lenticular striate. Where do you go? Wherever the catheter takes you, and then you just check a little bit if that's a good position or not. But I would not inject liquid embolics with the MSO. I would just inject glue in order to stay in the arteries and to stop as much of the flow as I can. Not long injections, just short injection in multiple feeders in the desire and hope that you would then have less flow inside the AVM, and that would be my main, most important goal to achieve. And if that succeeds, I hope that there will not be an acute complication, neither due to my treatment, but also due to the evolution of the disease, natural evolution of the disease, and hope that the gamma knife in the future will achieve more stable. Yeah. So that's.
Agreed.
Thank you.
I think I suppose there is some high flow fistulas compartment in the complex nidus. So maybe your first attack to the microcatheter has tendency entering to the high flow fistulas compartment. If you could occlude with glue, do not use DMSO, then you may have a high chance to reduce more flow into the varicose. And this varix, in the surface of the mural wall of varix is now inflamed, highly inflamed because of the flow. But if you could reduce flow, then you may have a chance to reduce the perifocal edema. Then radiosurgery will coming to the outcome is coming to the more favorable. Yeah.
Now I have a question. What is the status of glue or NBC like in China? Is there a glue in China or is it or is there's no cyanoacrylate?
Maybe we have NBCA. Yes.
You have NBCA. How many people are familiar with the use of NBCA in China?
I think 20% maybe.
Seldom in our hospital.
Yeah, I completely agree that glue is the better option for this. Yeah. Okay. Any other comments? All right, maybe I would love to have follow-up if possible. Maybe at some point we should, if you can, give us some follow-up about what happens in this case. Okay. Thank you again. And Nicola, you're up.
Hello. Hi, can you hear me?
Yes.
Yes, okay, perfect. Just share the screen. Okay. Okay, hope you can see it. I'm very happy to be here. And I wanted to share an overview of the dural AV fistulas of the cavernous sinus to point out some technical issues about direct access. First case, 80-year-old woman with classical findings, clinical findings of these fistulas. The drainage is towards the superior ophthalmic veins, which appears quite large. This is the geography from external carotid. She had no feeders from the internal. You can see all the feeders converge towards this single pouch. So we made combined CT. Anyway, we decided to treat it. In all case, in every dural fistulas of the cavernous sinus, our first attempt is from the inferior petrosal sinus, even though we couldn't see it in this case. But we failed. We made a couple of attempts, but we couldn't recanalize the inferior petrosal sinus. So we made the direct puncture of the superior ophthalmic vein because it was quite large, so it was easy to palpate under the palpebra. But I failed because I had, you see on the right image, I had some extravasation, spasm. So I was quite concerned, but we made a combine. There was just a very minor bleeding, very superficial, nothing behind the eye. So we changed the strategy again. We decided to do a direct puncture of the cavernous sinus at the junction point with the superior ophthalmic vein. So, as you probably know, our target is the junction at the level of the superior orbital fissure. Combined CT can help us. You can do this kind of puncture also with a standard rod method, but in our practice, so I mean, I find it very useful to use this software. You have this one is on a Siemens, but you have a similar one on a Philips. You can track your path. You can decide the target and the entry point, and plan the path, avoiding the nobile structures of the orbit. I mean the arteries, the nerve.
Was this the pathway you used? This is the final path?
Yes, it's the final path. So this was from the inferolateral aspect of the orbit, which is the usual one. I mean, if you do without middle guidance software, in the literature, in most of cases, this one is the one which is described.
No, yes, I agree. But here, this doesn't look very inferior. If you look at the axial on the left, that doesn't look like really much inferior to the globe.
No, not completely inferior. No. Subaxial. So you see on the angio image, you have an opening position, the middle path. The puncture is usually straightforward. In this case, we used a radial, for French radial sheath, which is quite good because it's rastromate, hydrophilic, traumatic. But the problem is that being hydrophilic, it's very slippery, so it is thin walled. So there is the risk of kickback of the wire as you insert the sheets because of the softness of the tissues of the orbit. In this case, it was easy, so we couldn't go with we could go with a standard colon catheter in the pouch with a few coils. The fistula was occluded. In this case, I don't know if you agree, but we prefer to do loose coiling also of the rest of the cavernous sinus up to the point of entry of the sheets to avoid backflow of blood in the orbit. And also, when we also injected a drop of glue, of squid in to disconnect the superior ophthalmic vein from the cavernous sinus at the level of the entry point of the needle. So this is the final angio. So this case was quite easy. I don't know if you want to discuss or have a slightly more complex one.
Yeah, so why initially, like, do you have an experience to go directly through the orbit, through the globe to the superior? Because I'm not sure how can that really work routinely. So my question, why you started like that?
I mean, we started some years ago before starting with a direct puncture of the cavernous sinus. We made some cases with at the beginning with a surgical exposition or exposure of the superior ophthalmic vein. Then in a couple of cases, since we found patients with very large superficial veins, we made a direct access by US guidance. I mean, I did it in this case because the vein was quite big and by ultrasound it seems to be very easy to access. But the problem is that these veins are very mobile, they are tortuous. So if you're not very experienced with ultrasound, you may lose the access as I did. So yes, probably in most of cases I prefer the access direct to the cavernous sinus.
And the other thing when you're oh yeah, there it is. Max commented on the approach. You know, if you use a 20 gauge needle and then exchange, which adds a step, one thing that is possible, and that's what we do, like you just use directly the 18 gauge, so you can just use that as a sheet and go directly with the microcatheter.
Yes, that's true. I have the feeling that using a sheet it makes all the rest of the procedure more stable, but I'm not sure about that, of course.
I don't think so, Nicola. I actually don't think so because the 18 gauge needle, by the time you go through all the tissues, it's actually very stable. Like, so that would be my comment. Is the 18, it's a bigger gauge needle, of course. But once it's quite deep in there, right? And so it ends up being quite stable. And I've seen at least one case of a complication at another institution trying to exchange for the sheath and like not being able to place a sheath, but now there's a hole in the back. So that's like something else to consider. But we're like,
sure.
These are comments on an excellent case. It's a great case.
Sure.
We're just like discussing more what the options are. My feeling is you're going to show more cases, but I just want to say that it's an excellent approach into the cavernous sinus. It's excellent. We use it more and more. Like it sounds dramatic. It looks like, oh my God, like there's blood coming out, all these things, but it really is like very straightforward, very effective, and I think we should use it more.
Yes, I think it's easier than it seems. If you want to go with the second one.
Yeah, let's go ahead.
Okay. Okay, this is another dural AV fistula. This is bigger. You can see from the movie there are feeders from both ICA and ECA. This is the, you can see here both. So there are feeders from dural feeders from the cavernous sinus, from the carotid siphon, and there is a big feeder from the MMA. They're not converging toward the same point. We made the convexity from both carotids, internal and external, and better this one. We made a CD, leaving also the bone, which I think is useful when you treat these lesions because you have more reference. And we can see in the blue one, the blue one is the feeder from external carotid, and at this point, I still have the doubt about what this is. I mean, it's a different compartment of the cavernous sinus, or is an involvement of the sphenoparietal sinus. I'm not sure. Anyway, there were multiple fistula points. And as usual, we started with an approach from the inferior petrosal sinus. Sorry with these movies. From you can see the IPS is very big, so I thought that access from there was very, very easy, and it was easy to get there. But from there, it was impossible for me to go in the large medial compartment of the cavernous sinus, in the big venous pouch. And after a lot of attempts, I could only get to the compartment fed from the external carotid. I put some course there, but from there I could not go in the compartment of the cavernous sinus and the fistula fed from the internal carotid. So I decided to go also in this case for a transorbital approach. I made another convincing CT because now we had the occlusion of the external carotid artery compartment, and also because the patient could have been moved a little bit. So made another one, and we used the new convincing CT, like in the other case, for a guidance. And in this case, you see, I found it useful because in this case, the approach was not from the lateral aspect of the orbit, but from the medial one, simply because of the bony anatomy. So I think it's useful to use these softwares. They are not mandatory, but they can give you some useful info. So this is the access. We use the same materials of the other case, but in this case I had a problem because I had, as you mentioned before, I lost the access because I get there with a needle. I could easily get with a wire inside, but the sheets couldn't follow the wire. After a couple of attempts, I lost the access. So I very, very quickly made another access, but I decided to change the material. And I used a NEF access set. Probably who has some body background may be familiar with this material. It's simply a sheet for drainage, for hepatic, the kidney stuff. So this sheet, which is thick walled, not thin walled, has a metal cannula stiffener. So once you are with the wire inside the cavernous sinus, it's very easy to follow with this one. And you see it was step forward. I use the wire provided with this access set, which is a 19/18 wire. Of course, now you have a very stable working channel. You can also go there with 2 microcatheters. For sure, it's not a very soft, very gentle material. But in this case, since I lost access, I wanted to be sure to have something very very stable, to not miss the target anymore. I had already used this material with good results. Just wanted to show there is a radiopac marker close to the tip, but not really at the level of the tip. So from the marker to the tip, there are a few millimeters. This is the set, but I think it's easily available everywhere. So once we were there with this set, we could do everything. So we made the catheterization of the large medial pouch with standard microcatheter and synchro wire. We made coiling. So at that point, most of the job was done. So we made coiling, a drop of squid to feel the interstices between the coils, and this is the final result. Okay, I have a very, very short other case, but I don't know if we want to discuss this one.
Any questions, any comments? Okay. All right, let's look at the third one.
Okay, this is very, very short, just to share another approach to know what you think about that. This man has a very, very tiny fistula. You see, this is from angiography, we can just see a very small anterior compartment of the cavernous sinus with the superior inferior ophthalmic veins clearly visible. We don't have a very huge dilation of the veins, but the symptoms were quite severe. He had chemosis, mild exophthalmos, but he especially had progressive, important worsening of visual acuity. Okay, you see from the CT the fistulous compartment, and we in this case I tried from the inferior pectoral sinus, but I couldn't access the anterior compartment of the vein. So after a couple of attempts, I made a direct approach, in this case with a Philips machine, but you see the guidance software is almost the same. So we made the plan, and we stick the vein with a small needle, and in this case we didn't use a microcatheter at all. We simply injected. This is a direct angio, and we injected some squid from the needle to feel the anterior compartment of the cavernous sinus and to have some reflux in the superior ophthalmic vein, and this was successful. Okay, so that's it.
So, Nicola, thank you very much. I think that very excellent and very simple way. Just one humble, simple question is that, did you try transvenous approach from the superior petrosal sinus, not the inferior, superior petrosal sinus? Have you tried?
No. Not
Okay.
in these cases anyway. No.
Okay, so
I tried from the inferior, but after a few attempts, I skipped to direct access.
Maximo, shall I share just my simple case?
Yeah, please.
Yeah. I stop sharing.
Yeah. Mhm. Okay, so I have to.
In the meantime, Nicola, would you tell people who don't know how high is the risk to puncturing eventually the internal carotid artery in the cavernous sinus with this procedure?
I think the risk is quite low, especially if you plan your access with a well-done convinced CT. At the beginning, so some years ago, with the first patients, I used to put a balloon in the carotid siphon. I think in the third one there is a balloon in the carotid siphon because this was not a very recent case. But actually, I'm not doing that anymore because I don't feel it is necessary.
But Dodi, I agree with you. It's a low risk if you think about it. For people, if you're not thinking prospectively about it, the risk is not so low. I have not our case, but I know of one case where that happened. Yeah. Michihiro, we can see your slides.
We're not hearing you, Michihiro.
Okay, it's okay. Sorry. So this is also as similar case as Nicola showed was impossible. Ipsilateral IPS was half thrombosis, and the superior ophthalmic vein also very tortuous and very difficult. So our cone beam CT showed clearly the shunt point. So also in this case, you see that what's so difficult to ipsilateral IPS is completely thrombosed. So we coming from here, though we didn't see superior petrosal sinus on the ipsilateral side, on the right side, but the superior petrosal sinus is a relatively constant anatomical structure. And once you could entering from here, this straightforward corridor is giving you the stabilization of the tip of microcatheter and relatively easy to entering to the exactly the shunt point. So if you failed to the bilateral inferior petrosal sinus, you may have another way coming from the contralateral side and entering to the superior petrosal sinus and entering to the fistulas. So please just keep in mind that this is also good way. Yeah, that's it. And this is the before embolization. This is after embolizations. Yeah.
Thanks, Michihiro. I guess like the reason the IPS approach evolved historically is because people were coming from below, right? Like thinking that an occluded IPS should still try to be accessed. Do you feel that the SPSs are just like should be thought of in the same way? Like every time we should try to find the SPS or like
if if IPS doesn't like to be the door to the shunt, then next door is for me the superior petrosal sinus. The third
before
door,
transorbital.
yes, and the third door is transfacial and transangular and entering to the superior ophthalmic vein. If all these door was still closed, then I will try to direct puncture as Nicola did. Yeah.
Okay. There are so many ways into that sinus, right? So, and a lot of it, I think, is just people's comfort and experience. Like once you get experience with certain technique. Thank you. Any other questions or comments? Nicola, thank you so much. I have one last comment, and that is about Nicola's last case. It's very illustrative in that it shows how the symptoms of the fistula are not so much due to the flow of the fistula, it's due to what happens to the venous outflow. Like you show the case of very small veins, small shunt, but you see how there's no outflow of the ophthalmic veins, right? There probably is thrombosis, or for some reason the outflow is affected. And so small shunt, and you have all of this like eye problems. So I'm sure,
Full
like,
agree.
we would deal with the shunt, we know, but for the larger audience, like to think of like, just because the shunt is big doesn't mean it's going to be that symptomatic. And the small ones can be really bad. I think the reason that's important is because when people see a small shunt, the argument often arises as, well, let's not do anything. Let's just wait. It's small. Maybe it'll close on its own. And it's true, it might. But while that's happening, the vision is being lost, right? We have cases like this. The person's losing vision, and the argument is, well, maybe we shouldn't do anything. So that's what my point is. I'm really quite against that. We should act based on the symptoms, and the small shunts can be very bad. So I just want to say that.
I have a short question about you because I don't have any experience for the orbital puncture. So how much is the risk of the risk of the eyes the problems with the eyesight or the eyeball movement after the orbital puncture? Is it high or is it quite
I
low, extremely low?
I think it's pretty low unless you have a retrobulbar bleeding. The thing you must avoid is to have a bleeding. So that's a point of advantage of cavernous sinus puncture versus intraorbital superior ophthalmic vein puncture. There are some reports of dark puncture of the superior ophthalmic vein inside the orbit behind the bulb. I think that's very dangerous because the vein is mobile and you can easily have bleeding. But the cavernous sinus is stiff, no? It's against the bone. It's not mobile, so it's difficult to have bleeding. You must avoid puncturing the nerve and the globe. But I mean, you feel the globe with your finger, so you can move it a little bit to make space to get in. So I think there is theoretical risk, of course, of vision problems, but in our experience, it's likely to be low, but also in the literature. But of course, there is, and I think that making a good planning of the needle track is mandatory to avoid any significant anatomic structure.
And how to avoid touching the nerves because the vessel is visible because you perform the DSA maybe, but how to avoid the nerve? You cannot see the nerve, right?
Okay, the optic nerve you can see it, so I think that's easy to avoid because you see it on combine, and of course it converges towards the orbital apex as well as the veins, but it goes in the optic canal. So if you target the superior orbital fissure, you shouldn't get there. You couldn't touch the third, fourth cranial nerve, but I think it's difficult to puncture other nerves. Of course, you don't see them, but they're very small. So I think there is a theoretical risk, but I think it's quite uncommon.
I think I agree. I had the same question as we had before, but as far as you coming to the lateral aspect of the eye socket and a bit inferior, then you never hit the optic nerve as well as the eyeball. So, and the majority of the tissue in the eye socket is not eyeball, not muscle, but fat. So, so if you have a nice guidance of on the X-ray and the navigation system, then maybe the risk is much lower than we expected before. But of course, the risk is not zero. But yeah.
Okay, thank you, everyone. Maybe we have time for one more case. Sophia, can you hear us? I think you have something to show.
I can hear you. Yeah. Good.
Great. Okay, let's go ahead.
Can you see it?
Yes.
Okay. This is basically just an anatomy question, but because you all are the anatomy gurus, I thought I would ask you what you thought of this. So I did this stroke case the other day. This was a 49-year-old gentleman who had actually presented 2 weeks prior to the incident stroke with stroke. And on that occasion, he had all these little small punctate foci of ischemia everywhere. He had advanced lung cancer. Ultimately, they just discharged him on aspirin, and then he came back on this occasion with a right MCA occlusion as well as an extracranial ICA occlusion. I think I'm not in the. Okay. So this is what I saw initially. We were able to easily traverse the ICA occlusion and get,
Sophia, we're seeing that, sorry, we're seeing the presenter view, like the one with the next
yeah,
slide and stuff, not the,
how about that?
yes, thank you.
Okay. All right, sorry, I had a lot of slides that were hidden that I didn't need to show because it's just going to take too much time. So that's why I got out of that. So my question is this, once arduously the recanalization was achieved, this was not the final recanalization, but I just want you to see the early arterial phase before everything is filling, and then the capillary phase, and there was this temporal area that was not perfused. And this is more or less like the best we got. And so I don't know if my cursor is showing, but this little branch right here, I thought maybe it's a very big anterior temporal or an early takeoff of an M2, and actually like it's a very short M1 stem. But so my question was, what is this? I tried to catheterize it, and the angiography of this vessel looked like this. Um, it looked like the posterior lateral choroidal, but this should not arise from the M1 stem, correct? So this was my question. What is that? And I will say it's possible that the microcatheter trying to navigate that, maybe I slipped because you can see on this injection that there is full filling through the circle of Willis to the contralateral side to the posterior circulation. But even if it, you know, traversed course, went backwards through PCOM. I didn't see the catheter turn that much, but there were many technical challenges. This was a difficult case. It was single plane room, older equipment, and not the least of which the machine actually stopped working in the middle and we had to transfer the patient. So I may have missed some like things that were happening live fluoroscopy, but I'm just very curious about this if you've seen this before and if you can explain this to me.
Interesting, very interesting. And could you show me again that the super selective injections of AP and lateral view?
I think those might be some of the slides that I have hidden, but this one here where there's not that much noise in the background.
Selective injection from the microcatheter you showed from this anterior temporal or somehow
Right,
branch
this one
from the
here.
yeah, this one, good. So for me, this is exactly part of the anterior choroidal artery supplying to the distal part of the choroidal brush you see. So intraventricular part. Huh?
Yeah.
So in AP view and the lateral view also already after entrance of the inferior horn of the lateral ventricle, which meaning the choroid plexal branch. So this is the plexal branch directly originating from the M1. So this is a quite unique anatomical variation, but there is some report, I think. So this is very beautifully you demonstrated. Part of the anteroidal artery is not one stem, as you know, that this is the very complexity of the ankle branch and intercapsular internal perforators and the lateral geniculate bodies and the ventricular part and the intraventricular part and anchor and hippocampal branch. So this is the complexity of this. So, but this branch is just one stem of the one of the distribution, which is a part of anterocoroidal artery.
And there should be the traditional anterocoroidal arising from the ICA.
ICA is there is some another stem of the anterocoroidal artery, but less developed compared to the normal anterocoroidal artery because of this additional supplemental supply from the M1.
Okay. Interesting. I've just put this picture up because of the tandem occlusion, which actually I did not revascularize the extracranial carotid. So I punctured the other side just to see that the MCA was patent. But then I thought this picture on the left kind of nicely showed the wire position vis-a-vis the posterior circulation. So you're saying anterocoroidal. Okay. All right, that's good. I thought I was looking in the literature to see if ever the posterior choroidal can come from M1, but this is less likely. It should be just a variant of
The reason why you see the posterior choroidal territory is because you're in a small branch you're injecting, so you're kind of it's to me it looks like you're seeing the collateral.
Gotcha.
Collaterally, you're seeing all the way there, right? Because probably you're occlusive and you're doing a good injection. But yes, this looks like. I mean, I don't recall having seen it before, but it's reported, and I know Michihiro.
Yeah.
Like a small supply to the anterocoroidal coming from.
Yes. Can I share my collection of the anterocoroidal artery? Or are you going to the next case?
Just real quick, I had follow-up a while back. I presented a case of this fistula patient. You all were very helpful to me. It was somebody he'd been treated like a couple of years before, and then on the subsequent angiogram, there was still some filling. Then basically, long story short, and so the thing was the patient had become completely aphasic. Although the lesion is on the right, he is left-sided. And the confusion was, the venous hypertension did not look worse. Why is the patient aphasic? And so after a lengthy discussion, kind of the advice was surgical treatment. And even if you can't be sure why he's aphasic, at least you get that out of the picture. So the patient did have surgery, and actually he improved. He started talking again. But this was the venous phase from before he went for surgery. You can still see the transverse sinus. And then, and this was like before he went for surgery again, like when the fistula was noted to still be filling by the small remnant. And then after surgery, the sinus is completely gone. They didn't ligate the sinus per se. So I just thought that was interesting. The patient's doing okay. He did have some infection at the operative site, which they had to go back and clean that out, but otherwise he's doing okay. But that's all I have. I can stop it so you can show your anatomical case that kind
So
of
the sinus was lost during the dissection.
Yeah. Which I guess it's a diseased sinus anyway, but all those recipient hemispheric veins were draining into it.
No, it was not. No, I think the sinus would have better. I think the sinus. It's too bad it was lost, but I'm glad he tolerated it.
Where is the exactly shunt point of this dural AVF?
It was at the location of the. Let me go back to that.
Could you show us that again? Where is the shunt point, exactly shunt point of this? Is the right transverse sigmoid or more inferior part of the sigmoid sinus, or?
It was at the transverse sigmoid junction. I think I stopped the share. I don't know. Oh, can I do it again?
Yeah, you can share it.
Yeah. It was at I guess you would say the transverse sigmoid junction. So the lateral limit, the distal end of the transverse sinus, which was visible on the ICA injection at the angiogram prior to surgery, but after the initial embolization, right there.
I see. So the vein of Labé is the initial exit vein, and this venous hypertension was coming through the vein of Labé, and the whole right inferior parietal and the posterior temporal cortical territory are fully suffering with venous hypertension, so-called pseudophlebitic patterns, which is the cause of his epilepsy or some neurological deficit, right?
Well, so yes, this was the presumption, although radiographically the veins did not show venous
Great.
hypertension.
Excellent. Thank you.
So then, Max, you saying unfortunate that the transverse sinus was lost. So what should I be watching out for him as I continue to follow him?
No, that's it. I think like so here, I think there's some venous hypertension and angio, and then it's isolated, right? The Dalbé wasn't draining into the sinus. The sinus is lost, but the left one is pretty decent. So the main issue is if they develop intracranial hypertension, right?
Again, like
If
so
they lose,
the delayed
but
signs of it. Okay.
yeah, but if he hasn't by now, he's not gonna get it. So he's tolerating it well, and
Yeah.
Yeah,
thankfully it's
yes.
fine.
Yeah. If the direct surgery are clearly so-called sinus rejections on the right, then the risk of the future recurrence of the dural AVF is less. What do you think?
Can you repeat that? You're
The-
saying that if
If that
the
this surgery is, I think, the best outcome for me, because the inferior affected sinus is completely now removed by the surgically, and the future recurrence on the same point of the dural AVF is now gone. So in my view, it's gonna be the best treatment in my view, as far as I see. Yeah.
But they didn't mean to take the sinus, Michihiro. It wasn't
Uh,
the fistula wasn't draining into the sinus, so they got away with it.
Yeah,
And
but
so
the
that's, you know,
superior wall of the transverse sigmoid junctions of the dural sinuses, that is a place, because this is affected with a vein of Rave, right?
yeah.
Mm.
Yeah.
Of course, it would be better to have the sinus open. But one thing that happened to us, I showed it also here on Bananas, is that we sacrificed the sinuses in the dural AV fistulas, and then in the follow-ups, they returned. So they reopened by themselves. It could well be the same if the sinus has not been completely damaged by the surgery, of course. If it was just occluded in some way because of the surgery, like a thrombosis, spontaneous thrombosis, it might come back.
Okay.
Mhm. Great.
Thank you.
thanks, Sophia. I mean, I would get like a follow-up MRA, whatever, MRI, make sure
Yeah,
there's
of course.
you know, the usual.
So,
Michihiro.
yeah, do you want to see
Yeah,
the,
please.
okay, wait, what's one there? Okay, this one, no? This is a superselective injections of anterior choroidal artery, typical anterior choroidal artery AP view and lateral view after finishing the embolization of the anterior choroidal artery aneurysm, and this is a reversed epsilon shape, is a so-called anchor branch of the anterior choroidal artery. And this is the magnified view, and this is the textbook by the Dural from the 2000, and here is our superselective angiography, and exactly Sophia showed this segment, so-called plexus branch, plexus segment of the intraventricular part was clearly, she showed, which is independently originating from the M1 point. And this is the magnified view of our cases, and here is a cysternal point of the anterior choroidal artery, and here is a branch supplying to the capsula internal and the lateral geniculate bodies, and this dominant stem is a so-called anchor branch, and supplying to the uncus of this hippocampal formations, and this is certainly the venous phase. This is showing the basal vein of Rosenthal, and this is another aspect here. That is nothing new one, and this is also the case. Exact very similar configurations of the intraventricular part that Sophia showed us this segment. So this branch is independently. So this is usually coming from the plexal point of the anterior choroidal artery, but this plexal point can be separated origins. One is coming from the ICA can be originating and also coming from the M1, proximal M1. That is already Professor Yashagir in the textbook showing. That is exactly what I learned. And this is the origin of the anterocoroidal artery. And this is the normal configuration of the plexal point. And this is the holoidal fissure. And usually this distance is around 20 or up to 22 millimeter in our base, our study. So if I going to the more magnified view, you see this is the anterocoroidal artery and the axial view, and here is the ankle branch, and this is a specimen by the cadaver dye infection. And this is our superselective angiography from the cone beam CT ankle branch, ankle sulcus, and here is the intrahypocampal branch ramification can be seen if that setup is well organized. And this is exactly microanatomy of the anterocoroidal artery, and which is Professor Abi and Professor from Monaco from the 19th century already well studied, and all the textbook I learned from the textbook is by the Professor Abi. So this is what I would like to share with you. Yeah.
Amazing, Michihiro. So Hale is asking how you do this on the chat. Can you briefly share your method, so forth?
You know that you don't need to insert a tip of microcatheter into the anterocoroidal artery, because the anterocoroidal artery certainly immediately separated to the several branches as we see. Therefore, the tip of microcatheter is just placed on the orifice of the anterocoroidal artery. Do not need to insert. Okay, then manual injections, APB and lateral, if you could confirm angiography, then try high resolution cone beam CT, either micro dyna CT or high resolution cone beam CT by Philips or whatever you have. But of course, under general anesthesia, and 14 second acquisition or 20-second acquisitions, depending on your DSA machine.
So you're using the power injector to the microcatheter?
No. From the microcatheter, there is no way to do power injector. So my hand is auto injector, 3 milliliter dual lock syringe. So just 2.5 cc contrast constantly over the 14 seconds or 20 seconds. That's it.
So you just have the practice of the timing of your push. Yeah.
You start injecting before. Push for a few seconds,
for
fill
sure.
everything, then start imaging.
Yes. So all the anterocoroidal artery arterial phase is filled with the contrast, then start to the acquisition, rotation angiography, 40 seconds or 20 seconds, high resolution mode, and continuously injecting the contrast over, let's say, 10 or 15 seconds. Yeah.
What's your dilution for Philips?
I do not dilute 100% pure contrast in this particular case, yes.
It's interesting because we also use 100%, but there are some, like Rahul, that suggest that dilution is better. So that's kind of unresolved. But the one thing that we need to tell people is don't use the 20% dilution. Like that's for flow diverters. That's not for this.
But
this stuff you need to use strong contrast.
Depends on what concentration of contrast you use. Not everybody has the same concentration, like 300, 200, 370, and so on. So that depends. What kind of concentration do you have, Michihiro?
Yeah, just as same as 100%, as the usual ordinary contrast.
Yeah, but you use what kind of contrast?
Contrast. Contrast either I have never paid attention, just the iodine, Omnipark, whatever you have here.
Yeah, but
I think we have 320. We have 320.
That changes quite a bit, the concentration. And we always use the same, so we always don't think much about it. But you know, when you compare people that uses more diluted contrast, like less concentrated, like 270, for example, it's like would be the same as someone else like diluting it 30% or so. So that becomes interesting when we try to compare the results of different institutions.
Are you afraid of any potential complications when you inject like the anterior corridor artery with the pure contrast without any dilution?
Thank you, Wei. But as far as if you are working on the anterior corridor artery aneurysms or AVMs, you have to need a supraselective injection from the anterior corridor artery, right?
Yes, but this is the AVM.
Yeah,
But for the aneurysm, we will
even
not.
by the aneurysm, you need to just check before and after embolization whether any thromboembolic complication was occurred in the territory of the anterior corridor artery or not. That is so. I have personally many experience with the so-called WADA test for the selective amygdala hypocampectomy patient before surgical resection of amygdala hypocampectomy, because in Zurich University years ago, Professor Yashagir and Professor Yonekawa had exclusively using the selective amygdala hypocampectomy for the very intractable epilepsy patient. And all the cases we had to do the WADA test from the supraselective injection from the orifice of the anterior corridor artery with Amitar test. And as I mentioned again, that the tip of microcatheter I never insert into the cisternal compartment of anterior corridor artery, just place the orifice of the anterior corridor artery. That is a safety, security reason, yeah.
Okay.
So I had seen that the one interesting question from Anil, in Sophia's case, how do you explain an older artery arising from the newly developed artery, which means the anterior corridor system arising from the M1? And that is a meaning the question as he wrote, I think, and very, very good questions in terms of the functional vascular anatomy. But even the cortical and temporal branch can be arising from the anterior corridor artery. So as Dodi always mentioned, that the artery is everywhere developed, as we see. Yeah.
Okay. I guess I think we're finally coming close to an end. We ran quite a bit late, but cases were superb today, and great discussion. So I think that's fantastic. Any questions, last questions, comments? Okay, thank you so very much, everybody, for coming, sticking around. We'll put this on, we'll make this available online again, and please spread the word about the regular banana, and looking forward to the next bananas. We'll do that at some point in about 3 months, I think. And thank you again. Have a good afternoon or night, and
thank you very much.
see you
Thank you very
all
much.
soon.
I always enjoyed all of your discussions and I learned a lot of things from your great expert presentation. Thank you so much.
Next time.
Thank you.
Bye-bye.
Bye,
Bye.
Dodi. Bye.
Thank you.
Bye.
Bye-bye.
Bye-bye.